Good morning, everyone. Great to be here for a whole variety of reasons. One, if I would have heard these talks prior to my conversation with you, I would have put my slides differently because they covered a lot of the stuff that I will be covering. But it's also, very pleased to see that the conversation is changing. The conversation that you just heard is markedly different than anything you would have heard 5-10 years ago. So we're in a new field. So it's good to be here, and you will see, and it's nice to see some of the same slides that I used are being used by lots of other folks. And what's the chicken and what's the egg, I'm not sure, but it's really great to be here. And it's great to be here on Public Health Week. So happy Public Health Week to all of you. And the theme of this year's Public Health Week is Healthiest Nation 2030. And I was just in D.C. talking with some of the federal agencies, and they're already planning for Healthy People 2030. So get engaged, because it is Healthy People 2010, Healthy People 2020, Healthy People 2030 will be about health in all policies. So get engaged, because it's happening right now. And then the themes, for the week, we started out raising the grade on Monday with our State of the State, and really highlighted the fact that we really aren't as healthy as we should be. Our grade is really actually pretty low as a nation, and we really need to improve it. And then it started talking about place matters and about building momentum and building broader connections, some of the things that you've heard about today. And now building on 20 years of success, well, I'm not sure. We've had some successes, but I think we're really starting in a new phase right now for building a new society of how we're going to actually create health in our society, and that's what we're going to be talking a little bit about, the new way that we need to be thinking about health. And certainly, as health commissioner, I pay attention to the state health rankings, and in Minnesota, the lighter the color, the better the health, and certainly we're in that top echelon of states. The healthiest states in the nation. So we're really doing quite well. So we really follow the Garrison-Keillor motto. Minnesota, where the women are strong, the men are good looking, and all of our health statistics are above average. Certainly, unless you're a person of color or an American Indian. And then issues change dramatically. So when you look at the things where they look at disparities in the state health rankings, you can see, and these are the only ones that they pay attention to, you can see in red, those are the things that are below where the white population are. So blacks and Hispanics generally are in worse state. The only place where there's a disparity that goes against the white population is in binge drinking. And we are one of the highest binge drinking rate states in the country. But if you look at everything else, particularly drug deaths, twice the drug deaths among African Americans than against whites. High school graduation, one of those social indicators. This is one huge issue in our state in terms of the disparities between whites and people of color in terms of high school graduation. As we were talking earlier, it's really about income and education and health, and they're linked. And if you can't be educated, if you're not educated, you're going to be really having problems with income and with health. Certainly chlamydia, where we have 10 times the rate of chlamydia infection among African Americans, 3 times in the Hispanic population. And infant mortality, an area that I've been working on for many years, double the rate for African Americans. So you can see that, as we pointed out in our Advancing Health Equity report that we put out over a year ago, that the opportunity to be healthy is not equally available everywhere or for everyone in the state. And that is particularly important to me as I moved to Minnesota in 1980. And as the director of the maternal and child health program for the city of Minneapolis, the issue that we were dealing with was infant mortality, and particularly the disparities in infant mortality. And so that's something for 15 years that I worked on to try to reduce those disparities. And you can see from 1980 to about 1995, when I left the city of Minneapolis, the rate was improving. And so I anticipated that the disparity would be gone by the year 2000. But when I became health commissioner in 2011 and looked at this slide, it became very striking to me that the black infant mortality rate in 2011 still had not reached the white infant mortality rate of 1980. That was shocking to me as state health commissioner, and said something needs to be done, something different. And that's when I reflected back on the definition of public health that I use quite frequently from Geoffrey Vickers, a British industrialist from the mid-50s. He said, the landmarks of political, economic, and social history are the moments when some condition passed from the category of the given into the category of the intolerable. I believe the history of public health might well be written as a record of successive redefinings of the unacceptable. And that's where I think we are right now. We have, and particularly with disparities, that infant mortality rate, that should be intolerable. But it's a given. We just anticipate, we assume that people of color are going to have higher infant mortality. That's an assumption that we make. We have an assumption that there are going to be greater incidents of violence in the black community than the white community. That's a given. But that should really be an intolerable. And I think also in this definition, it said the landmarks of political, economic, and social history are the moments. And so they don't talk about medical care, and they don't talk about, anything, the medical system. They talk about political and economic and social history. That's what's going to impact public health. And that's where we get at the health and all policies kinds of issues. And certainly, as I've been working on infant mortality, those disparities in birth outcomes are just the tip of the iceberg. If you look at all of the issues that are going on, all of the disparities that we have, they really are huge disparities, particularly with low income and populations of color and American Indians. And so as we see ourselves as a healthy state, it is because of the averages. But really, health equity is not about averages. It's about creating the opportunities for everybody to be healthy. So we really do. We want to increase the average health, but we want the standard deviation to decrease. We want everybody to be healthy. We want everybody to have equal opportunity to be healthy, and that's what we really need to work on. And certainly as I was thinking about this Public Health Week, April 6th to April 10th, I thought about when I was a senior in college. I took my first airplane ride. I know this is a long time ago, and so I was senior in college before I got in a plane, and I went to D.C. to visit my brother who was in law school. This was 2 days after Martin Luther King Jr. had been assassinated. And so this is what Washington, D.C. looked like when I got there, and I spent the week there. And it struck me for the first time in my life that I was in a place where I felt afraid. I was uncomfortable. I felt as a minority. I felt like this is a different place. And it struck me that I had to rethink about how I interacted with the world. And my brother, who was at Georgetown University, who had worked with migrant workers, really started to educate me about how what happens here is really an indicator of what we need to be worried about throughout the country. We really need to do things differently. And it was just fortuitous that 5 years earlier, in April of 1963, a letter from Birmingham jail, Martin Luther King Jr. said, "Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality tied in a single garment of destiny. Whatever affects one directly affects all indirectly." I use this quote frequently because people continue to say, why do people on the top want to worry about disparities? Why do people at the top really worry about what's happening to other populations? Because actually we are all tied into this web, and the data are showing that everybody benefits when everybody benefits. That it is not a zero-sum game. And that actually the health on the people of the top of whatever hierarchy is really brought down by the disparities that we have in our country. And certainly, as we see, the population is changing dramatically in this state. When I moved here in 1980, we had a population of color and American Indians of about 2%. It's now up to 17%, and 34% of all second graders throughout the state are kids of color and American Indians. So we are becoming an increasingly diverse state, and so it's a math problem. If we don't deal with disparities, that average is going to come down. So yes, we are one of the healthiest states in the country, number 6, but you can see that the trend is generally not going in the right direction. I had hoped, that in 2011 it went up for a couple of years, and I thought, yeah, that's because I was health commissioner. But I think that was just, it is going in the wrong direction. So if we are going to be a healthy state, we have to deal with those disparities. I think part of it is because of the increasing diversity, but I also think it's partly because of the policies that we've put in place, that were put in place over many years based on the white population that was here, that served the white population very well, but did not serve the new population that is coming into our state. So last night I went to the State of the State address, and afterwards in the little reception area where the governor was, Wendell Anderson was there. And so I had a chat with Wendell Anderson. And so I said, what would it take to create the good life for all Minnesotans? And for those of you, that's Wendell Anderson in 1973 on the Time magazine, holding up that Northern Pike, The Good Life in Minnesota. And in that magazine, it says, what stands out in Minnesota is courtesy and fairness, honesty, a capacity for innovation, hard work, intellectual adventure, and responsibility. And so when I mentioned that to Wendell Anderson last night, I said, I use that, and I said, it seems to me, if I look back at that magazine and what was going on, that you invested in the public good. That was the good life. You invested in education. You invested in community development. You invested in transportation. You invested in housing. And he said, yes, we did all of that, and people came together collaboratively to work on it. It is not like today when we have such disparity of people trying to be a zero-sum, a win-lose situation. We had people actually come together and compromise. And so he saw that we had changed, but that coming together to focus on the public good, on the commons, was what was really important. And I think, so as I was thinking, today is the birthday of Frances Perkins, who was the first woman appointed to a U.S. cabinet position. She was the Secretary of Labor, the longest-serving Secretary of Labor in history. And she said most man's problems, this is back when it was a man's world, and she knew better than anybody, man's problems on this planet in the long history of the race have been met and solved either partially or wholly by experiment based on common sense and carried out with courage. And certainly, so what would it look like to create the good life in Minnesota? Common sense says that we need to change how we do our work. As we look at the data, as we look at the experience, we have to change what we're doing. And I think it'll take some courage to make that change. So what I think that we need to do, and this fits in exactly with what we've been talking about, to advance health equity and achieving optimal health for all, we must change how we do our work. Particularly in the public health field, we need to change. And I think there are three things that we need to do to change our work. We need to expand the understanding about what creates health. We need to strengthen community capacity to create their own healthy future. Does that sound familiar? And promote a health in all policies approach with health equity as a goal. Health in all policies by itself does not necessarily lead to health equity. You have to have a specific focus. So you can focus on housing and transit-related housing, and you can become gentrified very quickly. So you have to keep health equity as a focus. But you cannot get health in all policies unless you first start focusing on those other two things, changing the narrative about what creates health and creating the community capacity to advance their own healthy future. Those are necessary if health in all policies is going to work. And so that, you mentioned it, and Kate mentioned it, work on the narrative. In expanding the understanding, that is part of our work. And we have to start looking at the worldview, which people bring to the table, which they bring to the policy discussions. And that worldview is shaped on community and individual and cultural beliefs and values and assumptions that then leads to these narratives, that leads to how we frame the messages that lead to policy developments. And this is the common narrative, the worldview that we see today. Bootstrap individualism. Everybody is really responsible for his or her own health. We have free market solutions that are there to make things all better. Small government and actually no government would be best. Science is suspect. Education is just about job training. And there really is no structural discrimination. That's a thing of the past. That's the common narrative. That's the narrative that frames all of the policy discussions. That's the policy or the narrative that frames how people get engaged and how they sometimes vote against their own self-interest because they still believe in that framework. And even just last week, as they were looking for the Raising of America, a video that's coming out that's sort of going to be focusing on child development, and they did some surveying. The public perceptions about why children struggle, the top of the list. Parents not knowing how to parent correctly. That's part of that narrative that it's all about the individual and the choices that he or she makes. It's all about the individual. Yes, fortunately, there are some areas in there where people are starting to think a little bit more broadly. but it is still about that public narrative. So to start to change that narrative, which I think is essential for us to really do this work, we have to start with that broad definition of what is health. And we are using the World Health Organization, that it's a state of complete mental and social well-being, not just merely the absence of disease or infirmity, and that it is a resource for moving forward with life. It's a resource for being engaged in our communities. It's a resource for thriving in today's world. And we're also having to focus the fact that health is not just about the individual. Health is about the context in which that person lives, plays, prays, travels, whatever you are saying, all of those things. So it's in that community. So as I go around the state and talking to people, the health of their community really impacts how they feel about their own health and how their own health is created. And so they're really worried about open space and recreation and access to healthy foods. Certainly there is concerned about medical services, but that's just one part of the piece. They're concerned about transit and affordable housing and economic opportunities and complete neighborhoods and safe streets and quality environment. They're concerned about all of those things. And when those things are absent, they don't feel good about themselves. They don't feel as healthy. They don't feel like they have the opportunities. And it's that opportunity that really embraces people and stimulates people. So we have to think about the individual in the context of his or her environment. And I certainly won't spend a lot of time, since we've already seen this kind of thing, but the point that we have in terms of changing the narrative is that with a broad definition of health and the individual health within the community, we really recognize that it's that clinical care, where we spend 95% of our overall healthcare dollar, really only accounts for about 10% of our overall health. And in addition to what Kate was saying, that 50% is physical environment and social economic environment, I also believe that 30% of health behaviors are influenced by the environment and influenced by policies. Because if you're in a poor neighborhood, if you don't have an automobile or have access to transportation, if you live in a neighborhood with poor schools, with no grocery stores, no farmers markets, no access to food, it's hard to make a good, healthy choice. So we can't blame people for making choices that are not available to them. And the environment really impacts the ability for people to make choices. So I believe that we're talking 75% of health is really impacted by policies that influence where we live in the environment. And so to expand that understanding, we need to point out the fact that health is not determined solely by medical care and personal choices, but mostly by living conditions. That is what has to be the key for that conversation about changing the narrative about what creates health. And likewise, the disparities that exist are not just because of lack of access to health care or to poor individual choices. The disparities are really mostly the result of policy decisions that systematically disadvantage some populations over others, particularly populations of colored American Indians, GLBT, and low-income populations. In our Advancing Health Equity Report, we identify that as structural racism. And being able to name that over and over has been very powerful to get people engaged, get communities engaged, particularly communities of color, to come to us and say, all right, you've identified it, and we've been looking at our own agency for what policies we have in place that are really structurally racist, and say, we will partner with you, and we'll criticize you, but we're doing it in the name of, let's all get better in this. Very powerful. So when we're talking about changing the narrative, there are some questions that we have to ask. We always have to question the worldview that people bring to the table. So these are just three of the questions. What values underlie the decision-making process? Because it's the values that really are at the basis of some of those policy decisions. What is assumed to be true about the world and the role of your institution or your organization? And what standards of success are being applied at different decision points? It's questioning the worldview. And I think when we start having conversations with people who disagree with us, we start talking about values and what we really want, I think we start to come together that, oh, really, we are all in this together. We are in that web that Dr. Martin Luther King Jr. talked about. People start to understand that, and it starts to change the narrative. And certainly so, from expanding the understanding about what creates health, we need it to strengthen the community capacity to create their own healthy future, the community organizing piece that is there. And our Healthy Minnesota 2020, how many people have been part of the Healthy Minnesota 2020 partnership? I hope there are some of you here, which really brought people from across the state together, from multiple sectors, from different parts of the state, really a broad array of folks to really look at what's creating health. What do we need to do in Minnesota to be healthy? And that helped, that was part of the conversation about what creates health. That was part of that changing the narrative. But it also engaged them into what we need to do to strengthen communities to enhance their own health. And so they came up with this framework, and you'll see in the yellow, some of the outcomes that they were working on. Certainly improved lifetime health, but reducing health disparities, more employment, healthier relationships. Those were the goals. Stronger and more stable families, better education outcomes. Those were the outcomes that we're really looking at. And I think what's really interesting, at least from my perspective, is the indicators that we're using as a state health department to evaluate the effectiveness of the state health department are these. Certainly prenatal care, breastfeeding, things that you're familiar with, but food security, on-time high school completion, per capita income, sense of safety, small business development, home ownership, and incarceration justice. Those are public health indicators that we have to be held accountable to. That was the other thing you heard. People need to be held accountable, so we need to be held accountable to those. And we're going to be held accountable because, as was also pointed out, public health can't do it alone. That's why the Healthy Minnesota Partnership, where we have people from transportation and education and housing and community development all together at the table, we all have to hold each other accountable for that. So, as we strengthen community to capacity, we talk about, health is not solely determined by medical care and personal choices. They're important, but they're not the biggest factor. We also now have to say, how do we make that change? How do we influence those living conditions? And that's where the community engagement, the community organizing comes in, so that we are in the process where I see community organizing as a public health tool. This is one of the new tools that we have to engage. And so we are in the process of organizing the narrative so that we can align the narrative of people to build public understanding and the public will. We're organizing people so that they can directly impact decision makers and develop relationships and partners and align those interests to actually move policy change. And we're trying to align the resources so that we can shift the resources to really enhance the policy developments that enhance health. And so aligning all of that and organizing that capacity to act, as Kate said, is power. We're trying to get power into the communities so they can impact their own health. And so these are some of the questions that we're having people ask when we're talking about looking at policies. What are the outcomes that you're looking at? Who's benefiting? Who's left out? Who should be targeted? The community has to be engaged in that. We're also talking about, if you're looking at how you're coming to those processes, who's at the decision-making table and who is not? Who has the power at the table? How should the decision-making table be set and who should set it? Who's being held accountable? And certainly as I go around the state and as I look at our own advisory committees and I look at hospital trustee boards and I look at the community benefits programs and I look at organizations of all kinds, who's at the table? Who's represented who has the power at the table? Which brings back the quotation from the letter from the Birmingham jail. After all sorts of things talking about just and unjust laws, a law is unjust if it is inflicted upon a minority that, as a result of being denied a right, had no part in enacting or devising the law. People who are affected by laws have to be at the table with power to help make the decision. So the third then, from that, changing the narrative, engaging populations. And I have to tell you that our Advancing Health Equity Report, our minimum wage report, and our paid sick leave report came about because of community organizing. The community came to the legislature and said, we want the health department to do an Advancing Health Equity Report. We want the health department to do a white paper on income and health. We want the health department to do a paid leave health. By the community asking the legislature, which then asks us, adds power to those reports. For us to do it on our own, it would have been just a report that a health department did. But because the community actually engaged in it and moved it forward, it was much more powerful. And so with us at the table presenting the data along with the community that asked for it, that's part of where we get the benefit of the data folks, because we've got a lot of data experts working with the community folks, coming together as a team. And so with that in place, you need to promote that health in all policies, which is the topic of this conference, but with health equity as a goal. And so I go back to Frances Perkins, and so she was head of labor. The Children's Bureau was in the Department of Labor under her, but they did the Civilian Conservation Corps, which is its birthday today, which had a whole big impact on health. Public Works Administration, National Industrial Recovery Act that she was responsible for, WPA, workplace safety, child labor laws, minimum wage laws, overtime laws, 40-hour work week, Social Security, all of these things was a health in all policies approach with the New Deal. Health in all policies and the New Deal were really one and the same. And I think it was really interesting. She said the New Deal began on March 25th, 1911, the day that the Triangle factory burned. Highlighted the fact that people, women and children, particularly low-income women and children, were burned in the Triangle Shirtwaist Fire, occupational health thing. For her, that was intolerable. It had been a given, but it was intolerable. So it was making changes to create that health in all policies approach. And I won't go through the definitions of health in all policies because Keisha has done that very well. But it requires practitioners from all sectors to collaborate to define and achieve mutually beneficial goals. But one example of that, when we put out our Advancing Health Equity Report, we were able to get every commissioner in Governor Dayton's administration to sign on to the Advancing Health Equity Report. So the Transportation Commissioner, the Education Commissioner, Human Services, Corrections, Employment and Economic Development, Housing, all signed on saying we pledge to work on advancing equity, eliminating disparities in our work. And so it's going to inform all of our policies. And that's been very powerful, and it's something that we continue to work on. And I think just this week, during Public Health Week, when President Obama came forward, I think we've always known the environment has an impact on public health. Communities can start planning for prevention and mitigation efforts related to climate change. Families and parents joining with doctors and nurses, putting some pressure on elected officials to make something happen. Identifying the fact that we all are affected by it and it's affected by policies. Framing global warming as a public health issue rather than an environmental or national security one produces more emotionally compelling responses among people. That's what I'm finding. When we bring the health people to the minimum wage conversation, when we bring the health people or the health issues to the paid leave conversation, it changes the conversation. We have more people around the table, and it actually encourages policy changes that are more important. Because people are interested basically in two things, jobs and their health. And when you bring those together, it's really very powerful. And I also think that we have to reflect back. This is the 50th anniversary of the 89th Congress, arguably the most productive Congress in history. These are some of the things that the 89th Congress did starting in 1965. Head Start, Medicare and Medicaid, the Voting Rights Act, Job Corps, VISTA, Peace Corps, school lunch, food stamps, neighborhood health centers, Older Americans Act, Elementary and Higher Education Act, housing, freedom of information, cigarettes, public works, humanities, community health center, on and on and on. A Congress that actually got something done. And they actually took a health in all policies approach. They recognized that, yes, you had to have access to medical care with Medicaid and Medicare and Medicaid. They knew that you had to have community health centers, but you notice the community health centers were part of the Office of Economic Security. They knew that was there, but they also, the OEO neighborhood health centers took a community-oriented approach, community-oriented primary care. But they also recognized you had to focus on education, you had to focus on housing, you had to focus on transportation, you had to focus on voting rights. They took a health in all policies approach and made some huge successes. As an example, so this is poverty, trends in poverty from 1960 to the present. And you can see that with the war on poverty that came about with the 89th Congress, you had some fairly dramatic decreases in poverty, particularly among seniors, which points out the fact that Medicare and Medicaid particularly Medicare, had a huge impact on poverty. But then you start noticing that it starts to rise in 1980, when we started to change some of our policies, again, to the narrative that we see today about individual responsibility and that there's a small role for government. We started to see some of the changes in poverty. Also, we worry a lot about healthcare costs. And from my reading of the data, up until about 1975 or 1980, our costs in this country for healthcare were about the same as all of the rest of the OECD country. When we started to move from that health and all policies approach, when we started to disinvest in public health and in community good, our costs started to rise. I certainly saw that in 1980 when the block grants came about. 1981, public health was cut 25%. We started to invest more in Medicaid than in public health. That's when our costs started to rise. I believe that it was that investment in public health and human services in the health and all policies approach that actually kept our healthcare costs down. And this is the African American infant mortality rate in red and the disparities between African Americans and whites. And you can see that we had fairly low the disparities were lower. They were still not adequate, that bottom line, until about 1980-81 when they started to rise. Again, the disparities increase when we don't have a health and all policies approach, when we don't have community good, when we don't invest in public health, when we don't invest in human services. So we're really using the World Health Organization, this has mentioned the social determinants of health, as a frame of how we work at a health and all policies approach. We've spent a lot of time, certainly, on the impact on equity and health in individuals and sort of on the the material circumstances, and our healthcare really works on that far right side. And public health has traditionally worked on that far right side. I'm thinking the new work that we really have to do is move to the left. We really have to focus in public health on the conditions that really impact social class and racism and education and occupation and income, because they have the biggest impact on all those material circumstances and the behaviors and psychosocial factors that affect individuals and their families. And those factors that influence education, occupation, and income really are impacted by those larger socio-political, socio-economic, contextual policies like labor market policies, public policies, cultural and social values. That is where the work needs to be done. And this is the work, this is the framework that we're using now with a collaboration that we're doing between Big Ten universities and state health departments in the region of the 11 states where the Big Ten schools are located, using this to see, can we change how academic institutions, particularly land-grant institutions, which really are charged to look at the social conditions and the economic conditions within their state, can use this framework to actually make a difference in reducing some of those disparities. And so these are some of the things that we've been working on at the State Health Department related to the social determinants. Some of the work that my colleagues in other states say, how do you get to work on marriage equality, on ban the box, on minimum wage? Well, I get to that because those are the conditions that create health. That's the definition of public health, right? You know, what we as a society do collectively to assure the conditions in which people can be healthy. Marriage, huge impact on health. And so when we write an editorial about the health impacts of marriage, really help shape the conversation about marriage equality in this state. When we look at incarceration justice and jobs, that has a huge impact on health. Our paper on minimum wage, in fact, that shows that as your income increases on the left, or as your income increases, on the left is the life expectancy, on the right is the number of days of poor or sick health. So you want the one on the left to go up and the one on the right to go down. And you can see if you move from the lowest quintile of income to the second lowest quintile of income, I mean, you're not talking huge dollars. You have 3.5 years of increased life expectancy. So I argue that the biggest public health achievement of the last legislative session was the minimum wage. That had more impact than I could ever do as a physician seeing patients in a clinic. That is where the impact really is. And our report of paid sick leave and paid parental leave, we're the only country, well, we're only one of 3 countries that does not have paid maternity leave. If you have paid parental and sick leave, infant mortality rates go down. Health of mothers and infants improves. Maternal and breastfeeding increases both in terms of the number and intensity and the duration. Vaccinations go up. Well-child checkups go up. Maternal depression goes down. Occupational injuries go down. Cancer screenings go up. Emergency room usage goes down. And actually, people use less time off when they have paid leave. And it also reported out the fact that those who most need paid leave, low income, lower educated, and people of color, have the least access to paid leave. That should be intolerable. But it's a given. It should be intolerable. That's where public health needs to be engaged and actually changing the conditions. Paid leave. Looking nationally, 10 weeks of paid maternity leave will reduce infant mortality by 10%. Now, what could that do to our black-white disparity in this state? We need to think about that. We need communities engaged in doing that. So the question that we ask in this whole thing about health and all policies, what would it look like if equity was the starting point for decision making? So that's what I'm asking for all of my colleagues in the cabinet, be they in the Department of Corrections or the Department of Commerce, Department of Transportation. What would it look like if equity was the starting point for your decision making? And so they're doing that. They're including that in their conversation, and it actually changes the conversation. It changes how we set things together. Certainly the Central Corridor Light Rail, where they went from a model looking at efficiency, how to quickly move somebody from one side of the cities to the other side, and actually put equity as the framework as part of the evaluation. It changed how they did it, and that's how some of those 3 stops came about. So what would it look like? I think our work would be different, and that's what I'm challenging you, that we really need to do different. But a lot of people say, well, I certainly get this from my colleagues in other states, but that's not our swim lane. That's not what public health is all about. Really, public health is not about swim lanes. I think we're about the pool. We want everybody to have access to the pool and be able to get from one end of the pool to the other in a safe manner. And so there's some tension in that. So as was said, Francis Perkins said, common sense says that we need to do our work differently, and it'll take courage. And that creates some of those tensions. And so Martin Luther King Jr. in 1963 of April, about around this time in 1963, my citing the creation of tension may sound rather shocking, but I am not afraid of the word tension. I have earnestly opposed violent tension, but there's a type of constructive, nonviolent tension which is necessary for growth. Just as Socrates felt that it was necessary to create a tension in the mind so that individuals could rise from the bondage of myths and half-truths to the unfettered realm of creative analysis and objective appraisal, so must we. We must create a kind of tension in society that'll help people rise from the dark depths of prejudice and racism to the majestic heights of understanding and brotherhood. That tension is good. We have to challenge how we've set things up. We have to challenge the policies that are in place. And we really need to organize. We need to organize the narrative, first step. And we've got a group of folks working on narrative. It doesn't just happen. We're purposely identifying tools. And so part of my presidential challenge when I become ASTO president in September is to change the narrative nationally. My goal as ASTO president is to actually have what creates health to be the conversation of the presidential campaign in the next session in 2016. The presidential candidates really should talk. It's not a partisan issue. What creates health? That needs to be part of the conversation. So we're trying to align the narrative. We need to align and organize the people so they're working collaboratively, and we need to really align the resources and organize the resources. And we have to invest differently. We cannot continue to invest 95% of our overall healthcare dollars in medical care when it's only 10% of the determinants of health. We need communities engaged to make some of those decisions about how we invest. That's why I like what happens here on this campus, where the Student Fees Committee, which really is the community, determines where they invest their student fee dollars. And they invest much better than I would have when I was director of Boynton Health Service, when I had that focus of that organization in mind. The community knows better than the professionals. And that's why when we look at health impact assessments, we really need to take the model that was on the Central Corridor. The health impact assessments need to be done by the community, with the professionals and the experts around the outside providing information. The decisions need to be made by the community. The best health impact assessments that I've seen are when the community takes ownership of that, and we as public health steps back and say, how can we help you? And we'll give you the information, but you get to decide how to move forward. This is not a new concept. CEO Winslow, Dean of the School of Public Health of Yale, who actually came here in 1920 to help dedicate a new health service, which was not called Boynton Health Service at the time, had this definition of public health. It's the science and art of preventing disease, prolonging life, promoting health. That was all what we kind of generally think about through an organized community effort. Certainly we deal with sanitation, communicable diseases, education, the organization of medical and nursing services. They need to be organized because they're important. But the development of the social machinery to ensure that everyone has a standard of living adequate for the maintenance of health. So organizing these benefits as to enable every citizen to realize his birthright of health and longevity. This is core public health from 100 years ago. This is the new work, that's the old work, that has always been the work of public health. And if you walk in, some of you may know, I was the director of Boynton Health Service, and on the front, as you walk in Boynton Health Service, which is a health service here at the University of Minnesota, there's this artwork on the bottom that's in the front entrance. And we commissioned that artwork to have the artist portray the Herophilus of Chalcedon quotation, which says, when health is absent, wisdom cannot reveal itself, art cannot become manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. Without health, you cannot do all of the things that certainly are important at a university, but are important in a state. Health is central to everything that goes on. But vice versa. In my ripping on Herophilus, when wisdom cannot reveal itself, when art cannot become manifest, when strength cannot fight, when wealth is not shared, and when intelligence cannot be applied, health is absent. It is a back and forth. There's a health in all policies, and all policies in health. We need everybody in this together. We need to work collectively, because public health is what we do collectively as a society to assure the conditions in which people can be healthy. That's your job, that's my job, that's everybody's job. Thank you.